So let's make a start. So hi, good afternoon, everybody. Thank you for joining this session this afternoon, for taking time out to attend the eFalls information session. Apologies to anyone that I've been bombarding with emails to try to convince you to attend this session. So my apologies. I was only just trying to make sure the right people actually attend this session. Because we've got so many new faces, or maybe some of you already work together, but I know we've got public health and ICB colleagues in this midst as well. I would suggest maybe we go through a quick round of intro, so as for us to know one and another. So my name is Abs. I'm the LCP project leader. I facilitate projects across Leeds, and I'm going to go to Dennis next.
Oh. Hi, my name's Denise Murray. I'm the Frailty and Proactive Care Lead for York Road PCN.
Hi, Denise. Thank you. Hannah, my work.
Hi, I'm Hannah. I work in public health in the Aging Well team, and we hold the funding for this eFalls stuff. So, yeah, I'm looking forward to talking to you all about it.
Thank you, Hannah. Danielle.
Hi, my name's Danielle Gunga. I'm the PCN manager for York Road PCN.
Thank you. Good to see you, Danielle. Helen.
Just checking there's no other Helens, which would often is. I'm Helen. I also work in the public health Aging Well team and co-chair the citywide Falls steering group with Joe.
Thank you, Helen. Graham.
Hi everyone, Graham Hyde, currently head of reporting at the ICB in Leeds.
Thank you, G. Francis.
Hi, I'm Francis Eyre. I'm a GP at Collingham and I'm the CED for Wetherby PCN. Obviously, we have high levels of frail patients, so interested in this project.
Thank you, Francis. Thank you for showing your interest in this project. Sarah.
Hi, I'm PCN manager for BWM.
Hi, Sarah. Rachel.
Hi everyone, I'm Rachel Shaw. I work in the LCP development team with ABS.
Hi, Rach. Claire.
Hi, I'm Claire and I work with Amley PCN as the Health Promotions Health Coordinator.
Thank you. Thanks for joining. Jenna, I know I've got Jenna on the screen, but I can see two colleagues in there.
Hi, yeah, I'm Jill. I'm an advanced nurse practitioner in Central North PCN.
And hi, I'm Heather. I'm one of the occupational therapists in Central North PCN.
Hi, guys. Thanks for joining. Chris.
Hi, GP up in Eden, PCN CD.
Thank you for representing Eden today, Chris. Will.
Hi everyone, Will Ridge, Senior Evaluation Manager for Leeds Place in the ICB. I will be only able to attend, I think, the first hour of this meeting. I'm going to step out at about 1 o'clock.
Thank you, Will, for dialing in. We're going to try and see if we're able to get to the evaluation bit before you leave. So thanks for joining. Hayley.
Hi, I'm Hayley, occupational therapist, and we provide some of the proactive care leadership to the proactive care team. We work at East Middleton and Hunslet PCN, and this is...
I'm Nicole, same as Hayley, occupational therapist within the PCN, so East Middleton and Hunslet, and supporting the proactive care team.
Thanks, guys, for joining. Joe.
Hi, I'm Jo Brayshaw. I'm the clinical lead for the Community Falls Service and LCH. Been working on the Falls Pathway across Leeds with system partners, co-chair the Citywide Falls Steering Group with Helen. Apologies, I will need to leave before 1 just due to other commitments, but I have managed to get in a bit earlier than anticipated.
Thanks for joining, Joe. We're going to try and cover your beat as well before you leave. Thank you. Stuart.
Yeah, Stuart Logan Nelson, Digital and Transformation Lead at Central North Leeds PCN. Just been asked to stand in at the last minute by Vin.
Thanks for standing in, Stuart. I think I've covered everyone. Thank you, everyone, for that wonderful introduction. I'm going to be bringing Helen and Hannah and Graham to speak to us about the eFalls project, which is an exciting opportunity. It's part of neighborhood health, which is the proactive way of working as per NHS. So, Helen and Hannah, if you don't mind me bringing you on first to kind of give a quick overview of the eFalls project, if that's okay.
Well, thanks, Ab. So I'm going to make a start in talking through the work that's been done in other areas, and some of you may have joined a session that we had with Wigan PCN earlier in the year, where they were kind of partway through their programme. So I'm just going to recap that for anybody who was there or anybody who hasn't heard about the work in Manchester. And then Hannah's going to talk about kind of in Leeds. So Greater Manchester were one of the first areas to pilot the use of eFalls, and have had kind of a research project running alongside this this concurrently. So in their area, this is just kind of an example of how they used eFalls. So they proactively identify people using eFalls, which identified within their Wigan PCN about 1,158 patients over the age of 65, and they focused on people that were between a 10 and 25% risk of having a fall in the next 12 months. Following clinical validation of that, 740 of those people were then identified as being kind of suitable for this approach, and were contacted initially via telephone, and had a set script, which we'll kind of maybe talk about later, something that we're able to share, a set script that was kind of based on insight around terminology to maybe use or not use, that things that kind of would not turn people off in terms of using the F word, falls or frailty, and that resulted in kind of a number of those people coming in for a face-to-face appointment. As you can see there, 198 people were then accepted a face-to-face appointment. Down the list, you can see that of those 198, 160 people then did attend a face-to-face appointment. And of those, then 125 people were referred on to the Strength and Balance offer in their primary care network area, and a small number didn't attend. So we'll go on to the next slide. So of those that were referred to Strength and Balance, that from those people that were identified using eFalls, they had 54 that were enrolled. It's probably also worth saying at this point, the approach that Greater Manchester took was that 10 to 25% risk, referrals on to Strength and Balance, but also signposting for eye tests as well. But that was kind of because that was signposting to kind of all the providers in the area. That's something that wasn't necessarily tracked. So yeah, and this kind of sums up kind of those people. For 54 people ended up attending and enrolling on Strength and Balance. Before we move on to Hannah, on the next slide, I'm just going to quickly talk through an approach that was used in another area in Keighley. So Keighley have taken a slightly different approach to using eFalls. They have, for part of their work, focused on people in the much lower risk cohorts. So they've taken a very small risk range, and people within the 10 to 12% risk of having a fall within the next year. And they took that cohort and signposted people with a text or email to their Keighley Healthy Living Service, who were delivering Strength and Balance programme. Unfortunately, we don't have any outcomes of that yet, because a lot of their data is still being processed, but we can share that once that comes through. But we just wanted to share a couple of examples around how other areas are using it to kind of give you a little bit of food for thought. Moving on to Hannah now, I think.
Yes, thank you. So this is an overview. I think hopefully some of this information went in the invite for this, but just as an overview of what this project is. So we are looking at the 10% to 30% cohort at risk of falls. Graham has some slides later to talk about how that's calculated and what that cohort looks like for each PCN. We are splitting the money equally between the PCNs. So depending, I think at the moment we potentially have 9, which would equate to £3,000 per PCN. There's the potential to amend that based on interest and deprivation. But at the moment, if we had 9, it's about 3K each. The expectation for that pot of money is that PCNs will contact a minimum of 50 people by the end of the financial year. We're then thinking that we'll do some evaluation post that, so kind of April, May. Keeping a record of the interventions. So like Helen just mentioned, that kind of who you contacted, any signposting and referrals, so we can kind of understand that pathway. And then we would like some attendance at feedback sessions. We're trying not to make it too evaluation heavy or kind of asking you guys to fill in lots of forms. But so we were thinking if we do more qualitative evaluation, which I'm sure we'll also be able to share a bit about that. And we've also said we have a preference about focusing on IMD 1 and 2 in your areas and people not living with severe frailty. So again, Graham can talk through what those numbers look like. And then in terms of what you'll receive from us to do this, you'll get the cohort lists again from Graham and Graham's team. We can provide you with resources to support conversations. So like Helen was saying, that script. Joe's going to talk about the falls pathway. There's resources that you could also give to people, and new resources are being developed as well. So we'll share all of that kind of the resources to support these conversations about healthy aging and falls prevention. The script there. And then we'll also give you information about strength and balance and community provision of physical activity in your area. Rachel and Abs are also going to help with that kind of link with local care partnerships as well, though. So that's the offer that we will support you with as well. And then I will hand over to Joe to talk through the falls pathway, which I think was sent out to you as well.
I was just going to ask if it had, because obviously it's quite small on screen for everybody, isn't it? For those of you familiar with the primary care falls pathway that we've had on Leeds Health Pathways, probably for a couple of years now, this pathway has been adapted from that to just incorporate, obviously, the levels of falls risk from the eFalls predictor tool. So it's been developed in line with initially the World Falls Guidelines, but then more recently last year when the NICE Falls Guidelines were updated. So in terms of following this, obviously starting at the top, it's just we're focusing on people that are aged 65 and over, but then it does come into people with 50 to 64 if they've got a health condition that increases risk of falling. So clinical judgment there too as well. Obviously, in relation to how we stratify that level of risk, we're looking at whether somebody's had a fall in the last year. If they haven't, then that takes us down kind of the low risk category. And as Hannah's just touched on in her slide, just around kind of what the opportunities are to make sure that we're encouraging people into evidence-based strength and balance exercise, so the programs through Active Leeds, and also kind of general physical activity programs, so that we're making the most of trying to keep people as mobile and as active as possible. So down that side, we have links on there. So anywhere where it's blue, it will take you directly through to the website, which gives you the information for Active Leeds. Say that top one where it goes through all the different strength and balance programs that are running in Leeds by Active Leeds, where they are, what time, what day of the week, how to refer. And again, the other links are also just kind of giving more information. The bottom one for Leeds Directory will give information just to the general public as well that they can read at their own leisure. And again, the same links into programs. So it's just different routes in that either a healthcare professional could provide or can be offered to the patient for them to look themselves if possible. If we've got somebody that we've identified they have fallen in the last year, it then opens up a few more questions just to kind of break down a little bit more in terms of that level of falls risk. So the main issues are looking around whether someone's living with frailty, 2 or more falls in the last year, if they've been injured from a fall, but they've needed medical treatment because of that, if they couldn't get up from the floor due to, after a fall, any potential loss of consciousness that's associated with the fall, and from a care home resident perspective, because that risk is greater. If the answer's no to all of those questions, then it's thinking about just what you're seeing of that patient, but also what the patient themselves is saying. So do they look unsteady on their feet? Has there been any recent deterioration in mobility? Or are they kind of saying that they feel that things have deteriorated? So again, if that's a yes, we're looking at promoting that physical activity and exercise, evidence-based exercise that would take them into the medium falls risk category. But what we're also in there is looking at the home environment too. So making sure that we've got the links through to Home Plus, so where they can do an environmental home hazard assessment. And again, that can be a healthcare professional that refers in, or it can be people that can self-refer through. The difference with the activity is in relation to whether somebody can access a group programme and whether that's the most appropriate and best place of care for them in relation to exercise. So obviously if they can, then it's signposting through to active leads. If they need to be seen at home, then that would be looking through obviously the neighbourhood team physio service to go out and see somebody there. If we go back to the questions, the additional questions, so if they answered no to those additional questions, it takes you down the medium falls risk. But then if they do answer yes to 1 or more, it would take you down the high falls risk. So that's where we've got that clinician being able to kind of dig a little bit deeper about what's happening with the falls and kind of key risks that we know that we can kind of modifiable risk factors that we can look at to try and improve. So around that postural hypertension, the lying and standing blood pressure, the medication reviews, the environment. Again, it links in with exercise as well. And again, depending on the appropriateness of that venue of where that would be. Again, there's links in. So wherever there's a blue bit there, it links you directly through to Home Plus's website. It directly links you through to postural hypertension guidance on Leeds Health Pathways as well. And in relation to any complexities with patients, if there's unexplained falls, potential syncope, unexplained dizziness, possible vestibular issues, then they would come through to the falls service. There is an element for urgent, I think, anticipating that this is probably going to be more of kind of the routine assessments rather than the urgent side of things here. What we have developed as well, in conjunction with the ICB, is that there is a falls assessment template that's been developed for System 1 and EMIS. So for primary care to be able to input there, and again, it gives information and links to the different interventions that can be used depending on what risk has been identified. And as I said at the beginning, this is all based on the primary care falls pathway that we had on Leeds Health Pathways. So there's more access to resources on that intranet page. So I can put that in the chat, and I'm sure Abs wouldn't mind sending that around separately if need be, that again, people can link into that. So it's got access to falls advice leaflets that can be printed off or emailed to patients. So again, that we're giving out written information that's consistent across Leeds, but it's also just got lots of different information for healthcare professionals in terms of awareness of different things that are out there to support their patients. Any questions on that whistle stop tour? Hopefully the framework of that is familiar to people, because the primary care falls pathway has been around for a little while. But if anybody's got any questions outside of this meeting, then I'm more than happy for people to email me directly.
I think next is Graham. Do you want me to talk through? I copied the slides over, or would you prefer to share your own slides? I'm happy either way.
Can I be a massive pain, because I've made a couple of changes. So could you take your slides down and I'll put mine up? Sorry about that. So here we go. My name's Graham Hyde. I work in the business intelligence team as part of the West Yorkshire ICB. I just want to take you through a little journey, if I may, just to try and explain what the EFI2 or eFalls actually is. So if you just indulge me for a little while, I'm finding the Leeds health and care system quite complicated at the moment. So a lot of my time is involved using Copilot to say, can you explain this to me as if I'm a 5-year-old? So that's what I did with EFI scores. If anyone can tell me in the chat what film the title is from, just do pop it in the chat, you might know. So what is EFI2? So really simply, if you imagine every person is carrying a backpack on a journey to a castle, along the way, some people pick up little rocks in their backpack. Each rock represents something that makes life just a little bit harder for those people, like having trouble walking, remembering things, or managing an illness. Some rocks are tiny and don't weigh much. Some rocks are bigger and are heavier. The EFI2 score is basically counting up how heavy the backpack has become at a part of the journey. Each time we find a rock or a health problem, we add up the right number of points. Small rocks have a few points, big rocks have more points. No rock, no points. When we add all of the points together, we get that EFI2 score. A small score means the backpack is quite light, and a bigger score means that that backpack is getting heavier and the person may need more help on their journey. So that's the principle of the EFI2 score, or eFalls. I can't just remember where the term eFalls came from, but anyway. So EFI2 score is a way of measuring how many rocks someone is carrying in their health backpack and how heavy those rocks are. So hopefully relatively easy to understand. So what is it? EFI2, it's an algorithm and a corresponding code list. It's developed by researchers. So Andy Clegg of University of Leeds fame, he developed the EFI Electronic Frailty Index score a while ago. He's obviously done a bit more work, got himself a bit more funding, and he's developed this EFI2. So it uses information on existing health deficit variables. So it could be signs, symptoms, diseases, disabilities, impairments, and it aims to predict the risk of an individual experiencing any of 4 frailty-related outcomes within the next 12 months. That could be new care home requirement, ED attendance or hospitalisation, a fall with a fracture, an emergency department attendance or hospitalisation with a fall or fracture, or care home admission or mortality. And the level of risk of experiencing the outcomes is then transformed into a score, which is used to construct frailty categories: fit, mild, moderate, and severe. The intended use of this risk score is as a population risk stratification tool, which identifies groups of patients likely to be living with varying degrees of frailty or at risk of frailty-related outcomes. What it isn't, it's not designed to assign individual frailty diagnoses, which should be based on clinical assessment and judgment having been first identified by this tool. The tool it's then over to you guys to clinically verify that those people are susceptible to a fall and part of the programme. So there are differences between the Electronic Frailty Index and EFI2. The biggest difference is that EFI2 basically adds or assigns weights to each of the individual variables. So EFI1 was based on 36 deficits. EFI2 builds on that. There's many more deficits, but add in those points and weighting. There's an updated list of variables, and it means clinicians should expect differences between EFI 1 and 2 in terms of patients identified within the mild, moderate and severe frailty categories. So, as I've said before, EFI 2 should absolutely be used in combination with clinical assessment and judgment to confirm a diagnosis or treatment plan, which I think is what we're going to do. There's loads of guidance out there from NHS England on the original EFI scores. And I think I've said this before, EFI2 is not for automatically assigning a frailty diagnosis of a person through this sort of use of coding. We shouldn't be doing that. So the full EFI2 code list, it's used, there's about 7,556 unique SNOMED codes or equivalent CTV3 and READ2 codes that are organized into 79 health deficit variables. So they're then split into different categories. 75 of those around asthma, heart disease and dementia, 3 around sort of alcohol, BMI and smoking, and 1 is around polypharmacy. A deficit is generally defined as being present if 1 or more of the EFI2 codes for that deficit are identified in the patient record. So all of this is as good as the information being recorded in primary care clinical systems. For EFI2, the target demographic is those aged 65 years or older, and that's exactly the same as what it was for EFI1. Once those deficits are identified using the various code lists, the EFI2 algorithm can be applied to calculate that EFI2 score. Essentially, EFI2 score is the sum of all of the points that a particular person has acquired as part of those deficits where that deficit is present. And as I alluded to before, the more points a person has, the bigger the score, the higher the risk. So there's a few slides coming up with a lot of numbers on, but I'll try and nudge you gently through them. So just trying to take all of that information and present it as some numbers. What's our opportunity? So when we've run the EFI2 algorithm against both EMIS and System 1 practices, because this was primarily developed developed by our colleagues in Bradford. Bradford only has System 1 practices, so we had to do a bit of extra work to mangle it in to use the EMIS world of practices. So at the last running of the data, we have identified 21,816 people across that spectrum of risk categories. That's what the EFI2 score has pulled out. So back to somebody else before said, there are some then, we've got that full picture, we then need to filter it down. So potentially this prevention or early intervention agenda could look at those identified in that lower risk categories, which is what we are going to do. So between the 10 and 30% risk categories. So I've just highlighted those. So it's the 2 columns highlighted in blue. And if you can see your PCN on there, those are the numbers that it's been identified without any additional filtering. But I'm just going to take you through some more filters. So we know that where you live affects your health outcomes. So I've just changed that table. So it's similar numbers, but we can see that cohort broken down into the IMD 2025 deciles. So IMD 1 represents the 10% most deprived neighbourhoods nationally and in Leeds. And we are probably going to look at IMD 1 and 2. So that's the 20% most deprived neighbourhoods in the city. Again, that's our potential starting point. So you can see that if you are from Armley PCN, within IMD 1, across all of the risk scores, risk scores, there's 261 people that you might want to have a look at, but we're going to refine that a little bit further. So our opportunity then, so because we sort of like to add things into Leeds and make it just a little bit complicated, we've also got the neighbourhood health agenda and the proactive care work going on. And as part of the proactive care work, we've identified the proactive care population. It currently stands at about 51,000 people, and that's made up of people with moderate and severe frailty and 3 or more long-term conditions. So we've had a bit of a think, and maybe we need to be looking at, so 29% of the people that EFI2 identifies as we probably should be doing something with them. 29% of those are already in the proactive care cohort. So we could maybe make a small assumption that as part of the wider proactive care work, those guys will be picked up anyway. So what we might want to look at is the people in that who are in the eFalls cohort but aren't in the proactive care cohort. So it's like that non-overlapping cohort. And this is the result of that. So that takes it down from that quite a big number of nearly 20,000 people. So there's probably about 7,000 people that we might want to start to have a look at. And I've again broken that down into the risk scores. And then we might only want to look at IMD 1 and 2, so they're 20% most deprived neighbourhoods. So those are those numbers. And where we've got that non-overlapping, if we then say, okay, we're filtering down all the time, we're going for our non-overlapping cohort, we're then going to only look at people in IMD 1 and 2, so the most deprived parts of the city, and we're only going to look at the 10 to 30% risk categories. And now we're getting down into much more manageable cohorts, and you can sort of see there are some challenges with this because Francis is here from Wetherby. There is deprivation in Wetherby, but not at the same extent as Middleton and Hunslet or BHR. So where you can see Wetherby, they've got 6 people that have been identified. That's probably not enough, but we could widen that. We could take that filter up, particularly for Wetherby. We could introduce IMD 3 and 4 perhaps. So those are the sort of numbers. So if you hear from Armley PCN, there's about 106 people that we reckon you could have a go at. I think the scheme is maybe looking at around 50, but you've probably got enough there to have a go at. So that's all I wanted to say on the how we create the numbers, where does it come from, and then what the numbers are. So hopefully we've gone from a big number, a big cohort, we've appreciated that some of those people are already in the proactive care cohort. We've filtered it down a little bit more into the most deprived neighbourhoods, and we're only looking at the 10 to 30% risk. And I offer you that as a possible way forward to rolling out the eFalls work and the Falls pathway. I'll stop sharing. Any questions? Can you make an easy question, please, Chris? Thank you.
So on the presented, I mean, I'm out as a PCN, but can I still use the Falls tool outside of the payment thing, just to, because clearly we've still got a lot of people coming up on the Falls tool. We're just not the area that you're interested in. So can I still use it to narrow down our lists for proactive care anyway?
Yeah, I mean, I've got no problem with sending you the non-overlapping cohort for Yeadon. We can add the risk categories on as well. So yeah, I mean, I've got no problem with sending you those numbers. No, not at all.
I was just going to say that because we don't use the tool in Leeds yet, I think we'd be quite happy to, like Graham said, kind of change some of those parameters. And if you even were interested in still being part of it, I think you still can have a bit of funding and do the test and learn and just see how, is this something we want to use in Leeds? Hopefully, yes. Hopefully it does help with that wider falls prevention agenda. And I guess that would then be chatting to Graham about how we get to a point where you've got at least 50 people and then looking at the process of doing the eFalls and then the referrals through for that proactive bit. But so I think for the test and learn, Yeadon could still definitely still be in, and we just look at a different way of cutting the data for that.
Yeah. So if I have just done some analysis on the fly, Yeadon PCN, if I just add in IMD 1, 2, 3, and 4, that takes the total up to 32. So we shouldn't be excluding people. Well, yeah, there is an opportunity in Yeadon, shall we say. People in the room, Jenna?
Jenna and Heather, you're on mute.
Sorry, we just wanted to say, can we have the numbers sent through to us as well, please?
Absolutely. Yeah. Sorry, I'm in control, aren't I? Will, sorry. I'm not paying enough attention.
You are in control. Sorry, I'm just jacking up my desk just so I can stand. But just to say, I think one thing to bear in mind is if we're going to use any kind of quantitative approaches like control cohort approach or anything with this cohort, if we have PCNs who are using it who are not sort of formally part of the pilot or who are just using it to sort of test it out, we just need to keep an eye on that just to make sure that we can account for it in our methodology.
Thank you. Hayley?
So can we just be clear then? Are we able to use this for our current proactive care cohort or not? Because when we've got our numbers and we're kind of contacting them to kind of verify their degree of frailty, and then, you know, some of them might, after the verification, might come out as mild. Could we potentially use this for those mild ones that aren't necessarily getting kind of like the home visit side of things, but are possibly needing kind of like the falls stuff? Would that fit within this criteria, even though they're coming under the proactive care cohort, if that makes sense?
Yeah, it does. So I suppose we did have a bit of a moment a few weeks ago thinking maybe the opportunity for this eFalls stuff is actually in the people that are not already in the proactive care cohort, because they should be being picked up in that work. But listening to what you've said, using the eFalls work and matching it into your proactive care cohort, that gives you actually lots more intelligence about your proactive care cohort, doesn't it? That this group of folk actually could benefit from being sent down the eFalls pathway. So I think my answer is yes. I think it adds that extra layer of detail for those cohorts of people that you're probably already looking at.
Okay.
Does that make sense? Does that answer your question?
Yes, I think so.
Cool. Hannah?
I was just going to add to that in that, yes, the eFalls tool is helpful for the general proactive care, and that is where we would like it to go. I think just my slight difference to your answer is that the funding for this is to have those people who maybe aren't in the proactive care cohort, or at least that's what we would like to see. I realize things are a bit tricky and numbers might not work out, but I think we were thinking that with the additional funding, this would be to support those people who weren't already picked up. I'm not too, yeah, so Hayley, like you're saying, if there are people who you identify and they follow the path, that's brilliant. And it's all learning, and we are still trying to support those people. But I guess this was an extra bit to say, if you could also look at the people who aren't in those proactive care lists already, who will already be seen, this is to see if we could get those people who, before they've, like Helen said in the chat, there are people who've had a fall but haven't gone to hospital. So can we get those people who haven't presented with a fall yet? So yes, to Graham's point, but also hopefully this is gives you a bit of time and capacity to also look at those people even further or even earlier on in that kind of risk section.
And if I could just build on that, so if I can speak openly and honestly, there's money available under the PCN LES to scale up proactive care in the city. So there's money available in that pot. What Hannah and Helen are proposing is there's also some funding available for this falls work. But let's be honest, you can't get paid twice for the same person. I think that's a bit naughty. I might have spoken out of turn there, but that's just what I think. Chris?
If I'm honest, with a PCN hat on, I'm not that interested in the £3,000. It's just confusing for me because I've already got one scheme and then I've got another scheme and then I've got this complex cohort in or out problem. Whereas the problem I'm trying to solve is I've got a big list of people in the proactive care group. I know that half the names in there shouldn't be in there. And when we dive into it, we'll spend a lot of time working out that we don't need to talk to a bunch of people. So what I was really hoping for was a second cohort on top of the first cohort. Proactive care is a broad cohort. We then got this falls cohort. You overlap the two, and then I've got some names that I can go at, and we'll spend less time deciding that we're not going to have to work with some people. You know what I mean? So I'm looking at this as let's be more efficient with care coordinator time in picking who they need to see, and not wasting time. So, and what you're proposing prevents me from doing that, which is why I was somewhat slightly pleased when I wasn't in IMD 1 or 2, and because then I could just get the data that I want and use it how I want for my teams. But I don't know then how that stacks up for your analysis of what this does, if you know what I mean.
Okay, so can I just for my own understanding, so we've got a lump of people in the proactive care cohort that we're sending out to PCMs, and we've got a lump of people that we've identified through the eFalls cohort. Is what you're saying, Chris, you just want both big lumps of people because the second eFalls cohort gives you a bit more intelligence about that proactive care cohort to do stuff with? Is that what you're saying?
That's my assumption, but I don't know until I've seen the names and looked at the lists. That's I don't know if other people are thinking like that.
Okay, that's useful. Claire?
Yeah, I don't know whether what I want to say adds to what Chris just said. I've also noticed on our lists, more than half of the patients don't really qualify for the proactive care. So if, from what Hannah said, if we decide that half the people in IMD 1, 2, 3, 4 under the proactive care list do not qualify, and we don't care for them under that umbrella, but instead, if they're the same people overlapping on the eFalls category, and we take them under that category, do we still don't get funding, both fundings? Because at this point, we would have decided not to care for them under the proactive care scheme. Because majority of our patients are under mild. What I've noticed, they're having mild or even no frailty at all from our systems. If you look at the clinical systems from our end, actually we are wondering where did we get them coded as severe or moderate from your end? So if these patients that are mild from our clinical systems are overlapping with the eFalls, can't we just work with them that way?
I think the answer's got to be yes, isn't it?
Or
I
do
think
we expand it from just IMD 1 and 2? Because I had a discussion with one of the practice managers and wondering someone might be staying in IMD 5, 6, but when actually they're deprived as people, someone may be staying in an affluent place, but on personal level, they're not. So do we just expand the IMDA to bring on more people that qualify, or we deal with just those IMDAs?
so. From my perspective, I don't mind, but I suppose I'm sort of looking at Hannah and Helen really for this is sort of their scheme. I think I'd be looking for a bit of guidance. I mean, maybe we need to take this away and have another think about it. Because I'm not sure I've got the answer to that right now without some thought.
Yeah, I think it's interesting as well, kind of listen to your points, Chris and Claire. I think, this is really it's probably over a year that we've been extremely excited and passionate about trying to test getting this going in the same way that Greater Manchester have. Hence kind of this piece of work being a test and learn. So I think it's something for us to kind of be thinking through around, what ideally we'd like from the programme, it being kind of people that aren't in the cohort, and in IMD 1 and 2, people not living with severely frail, but listening to what I think you said, Chris and Claire, around those people living with mild frailty, this feels like also, if we don't look at those people that are not on the list, but actually this could be an opportunity for looking at those. So maybe we do need to have a little think about that. Hannah, have you got any other thoughts in addition to what I've just said?
I feel like my main two things are like Graham said about if anyone challenged us for PCNs being paid twice for the same person. I think that's a thing that feels not great in the current financial thing, but also that, like Helen said, this is a test and learn. So I also kind of feel that if a PCN has an approach that makes sense for them and we are working with the right people and we're getting the right people at the right time to the right intervention, it's a small number of people we're asking you to work with. So it's not changing the way the city works necessarily. So I would be happy to, on a PCN by PCN basis, kind of go with what makes sense. We look at what that looks like at the end of this and then come up with a plan for the city. It is a small amount of money. It is a small number of people. Will might have something else to say about that from an evaluation point of view, but I think as it's a test and learn, I think I'm quite keen on the testing the process bit and what this would look like if we expanded it further and built it into proactive care, because I think that's where it's going. It would be embedded in proactive care and neighbourhood health, so it's not a separate thing. I don't know if that's helpful, but Dr. Sangha?
Yeah, so just a point that Chris made, and just going back to that. So the issue is with the list and who comes up with this list and what tools they use to get people on this list. So if someone who's on the proactive care list and our clinicians have actually physically seen them and they don't think they should be in the proactive care list, but they got mild frailty, the issue is with the list. And if they then refer the patient into strength and balance, it just makes sense that they should be in the other list in the first place. So the problem is initially with the list, not with the clinician who is actually reviewing the patient. So I think Chris' point makes sense that they should be accounted for. And these patients, if they're on the proactive care list, they're being assessed by an ANP. It makes sense that the issue is with the list and not with the clinician's sort of assessment, and they should be taken into account when we're doing the eFalls referral. I hope that makes sense.
I think that seems like it makes sense.
Any other questions? Will?
Yeah, I mean, just sort of picking up on the point that Hannah makes, I think judging by quite a lot of this conversation, I think there is quite a lot of sort of useful process focused qualitative evidence to gather on this. In terms of the more quantitative end, we're thinking about ways in which we can do it. There's a similar piece of work going on in Bradford that we're looking at shamelessly borrowing some of their techniques on this. But I think in the first instance, it's gonna by it probably needs to be qual first, and then qual and process first, and then have a look at what we can do after that. Partly just because of time frames for this kind of thing, and we always sort of say we need quite a lot of time to be able to pull out any useful findings from quantitative data. We also know that these kind of tools and things, as you're sort of saying, it feels like there's sort of a few references to 50% hit rate on proactive care, and we know that from things like working with the previous e-frailty measures and things, that they're never, that they're never 100% accurate. They're always picking up on stuff and identifying people, which generally speaking, when they're reviewed by a clinician in practice, they're not as frail as maybe they're being labelled up at the time. So it's a known issue.
I feel like that might lead on to the bit about evaluation, which I realise will you have to go in 7 minutes. So I'll just share this quickly. So this is the logic model that we have for this piece of work. Just to kind of highlight that the goal of what we want to do from this is we want to make sure people are being proactively identified, they are having a conversation about falls prevention and support. The public are also aware of the risk factors and how to prevent falls. We're aware that some of the people you might be speaking to haven't had a fall. They don't necessarily want to be referred strength and balance yet, but that kind of wider public health thing of awareness of falls prevention and risks. Staff are more confident, and people are aware of the services around. The wider population of that is that we are all aging well, people are having their meds optimized, better uptake of falls prevention, better conversations, and staff are feeling valued. And then the whole population is that we're reducing the risk of falls. So kind of we do have bits that we will be doing for evaluation under this, but just to say that this first box is kind of where we're trying to get with this piece of work, and that's what we're interested in particular. So the next bit, so this is kind of the expectation we'd have if you did want the funding for this, was to share the model that you tested, whether that's, like Chris was saying, kind of you're using this in your proactive care cohorts to find the right people and have those good conversations, or whether you're just contacting people you haven't heard of before. We can have a discussion about what that model is, details of what you did. Are you kind of calling people, sending texts? Did you do a group event, or actually you just invite everyone for a larger thing, and kind of where you signposted and who you referred to, and then your views of that process. So we're thinking that we'll have a workshop in April, May, and it would just be a request that you come to that and tell us what you thought of it. And then the wider project support is kind of that code stuff, the stuff Graham's been talking about and Will, about what happens with people, and the outcomes from there. We can have a look at monitoring data for strength and balance about who was referred and did they actually, were they appropriate, did they start, what happened there. And then the local care partnership development team can also help with engaging with wider LCP partners. So we're aware the PCNs are very busy. We're asking you to validate the data, make those contacts, and then wider LCP partners will also be able to support with some of that referral data, signposting, social prescribing stuff. So the last bit in the 4 minutes before Will leaves was kind of, what do we want to do now? We need to agree when people want to sign up to this. We can then process the data, the funding, send you the data, and kind of get started. So the next bit was just, what do we need in order to get started on this? So I will stop now, but that's kind of in terms of evaluation, what we want to know is, does it work and how does it work best? And it might work best in different PCNs for different groups of people or whatever, but that's what we're interested primarily, I think, with this fairly small amount of funding and fairly small number of people. But yes, so does anyone have any thoughts? Will, if you have any thoughts before you have to go in 3 minutes, but
I think Dr. Sega, you've got your hands up. Any thoughts?
Yeah, just wanted to ask if, in terms of looking at the list, and is it a clinician then having to look at the list of patients before then checking and deciding if it needs sort of referring on to the strength and balance? Because some of it may not be suitable for the strength and balance, looking at the leads, the pathway. Or do you think when we get the list, they'll all will be sort of in that mild category and we just blindly refer them? Or do we need to actually evaluate the entire list? Because there's a lot of patients for not a lot of money and funding if it needs a clinician's time. And then that question then is, how is the funding going to come into the PCN? Is it going to be per patient, or is it going to be just equalized across? Because obviously that's going to be very different, because some PCNs will have a lot more. Yeah, just trying to figure out. I know it's not a lot of money, but I'm just trying to figure out how it's all working as well.
Thank you, Dr. Sega. Helen, do you want to come in there? You're on mute, Helen.
Sorry about that. I was just going to come in about your point around kind of, are you required to see all those patients? I think as this is a test and learn, we're keen to see what approaches different PCNs can take. So with the Keithley PCN, they identified from their list of people and from their clinical knowledge who they thought would be suitable for strength and balance, and kind of did some kind of mass communications around that. It might be, as Hannah mentioned, it might be that in your PCN area with the LCP partners that you want to do an event where you invite, again, a whole host of people on your list. Or it might be that you know that there's some cohorts of people on your list that actually would really benefit from kind of a structured conversation, and that you know, that better conversation in terms of addressing people's perceptions around kind of their falls risk, etc. So yeah, it is we're not kind of prescribing the approach. It's really for kind of you all to look at your lists and work out who you think would benefit from this and how you might apply it within your PCN area. Anything else to say on that, Hannah?
No, I think like you just said, Helen, we're happy with you to test an approach, and let's see if it works. So yeah, no, I don't think everybody needs to have an appointment with a GP. I think, yeah, looking at kind of their records or the level of frailty or whatever, making a decision whichever way. And also because it's only 50 people out of those lists, I think you can also choose which those people are. We would like you to focus on IMD 1 and 2 if possible, but you also don't have to.
Thank you. It's a PCN-centered approach way kind of project. So the ball is in the PCN court, and to find the patient the best way possible. Chris.
So we've got two broad categories. We've got a lower risk people who aren't really in the proactive care, but you want to get ahead of the game and try and entice some of those into strength and balance training. And you're not asking for a full PCN proactive care approach for them. You're asking them to look through the list, make a judgment about who could sensibly be sent information about strength and balance training, and then you'll see how many of those take it up and what happens afterwards. So that's one group, and that's what the small amount of money's for. It's somebody just to go down the list, go sensible, 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 and then decide how we're going to get in touch with them and highlight it. And that's one group. And then the other group, which is what I had in my mind, which is I've got a proactive care list, and I just want to hone down a bit more on that and add this in as a different view on the really high risk people, and then try and maybe target a subgroup of that. So that's the two proposed things, and the PCNs can make that decision about which they want to be in. Yeah, thanks.
Thank you, Chris. Yeah, I think you summarized that very well. Yeah, it's two separate groups, and I think your PCN can be in both if you want. And we're hoping Yeading stays in both the eFalls and the proactive care. And yeah, you've got great local assets as well in Yeading to help support the eFalls if you decide to go that way as well. So we're hoping that happens. I think according to the last slide, Hannah, the one you showed, we just hoping to find out when will the PCN want us to kick off this project. I believe it's for 12 months, or is it?
We've got the funding ready. We can sort the data. We can get started with the funding. So it's just when is a suitable time to say, do you want the funding or not? I guess is kind of either we can decide now, or people may need to go back and talk to their teams. But as soon as people are happy, then we can talk to the GP Confed and get the money sent over. So from our side, I think we are ready whenever PCNs are ready as well.
Anna, sorry, just to check, is it till the end of March, or is it for 12 months?
So we've done till the end of the financial year, because again, it's only 50 people. So yeah, till March. If that doesn't feel right, then we can talk about that. But I think that it's probably enough time to see 50 people. And then, like I said, April, May, we'd kind of look at having a workshop to talk about the process and feedback for that.
Okay.
I think people have asked if they could have the slides as well. Oh, Helen's just said that we'll send them round.
Okay. All right. So I think Chris has said you don't like to speak to their PCN. Okay. Okay, I think if we go in by PCNs, I think different PCN have got different opinions. So yeah, I'll reach out to the PCN separately after this meeting to see when they would like to start, and maybe we just go by PCN, since we're thinking of PCN-centered approach with this project as well, and work with different PCNs separately. Okay, if that's okay. All right. Thank you.
Perfect.
And if you have any other questions after this as well, please do feel free to reach out, and I'll cascade the questions to the right team to respond as well.
Thank you for coordinating us, Abs.
Thank you guys for a wonderful presentation, and we'll share the slides after this as well.
Thank you.
We get half an hour back.
Yeah. Thanks, everyone. We were worried about how much we had to cover, but yeah, it was great. We've had a lot of discussion, a lot of questions, which is good, but covered a lot in the time. But thanks, Abs, for pulling us all together and getting everybody engaged.
Thank you.
Thanks.
All right. Good to see you all.
See you later. Bye.
Bye.
See you later.